the Ohio State University, by the way, which I've only been there for 2.5 years, so I actually got in a lot of trouble for the first year I was there for not putting the "the" in front of.
We're the University of Chicago.
Yeah, that's right. I did notice that, actually. There was the University of Chicago, and it's on the buildings everywhere. So yeah, I have the distinct oddity of being cross-listed in geography and epidemiology. And people often say, where, how, why? What does that even mean? So I'm actually a health geographer. There is a subdiscipline in geography called health geography. UNC Chapel Hill, which is my basketball home, just in case you were wondering, has one of the few health geography programs in the US. But what it means is that you essentially end up with a degree in epi or biostat in the end as well. So when I moved to Ohio State University, they gave me a joint appointment thinking that I spanned the two disciplines really well. And what a lot of my research does do is it looks at human-environment interactions, and this is inherently spatial. People live in places, and that to understand health and education and all sorts of outcomes, we actually really need to understand the places that they're living and interacting within. And so that sort of grounds a lot of my research in general. So today I'm actually going to talk about Bangladesh. I've been working in Bangladesh for about 15 years since I was a graduate student at UNC. And I started there working with the really early vaccine and oral rehydration therapy programs that were done to help improve children's health. And since then, I have sort of evolved my research, and it's moved into understanding larger social and economic dimensions of change in Bangladesh and how that relates to health in the end. My personal interest is in health. Bangladesh is a really fascinating country in a lot of respects. It was the only country to partition or break off from another country during the Cold War era. Germany, Pakistan, Israel, a number of other nations split and reshaped in the immediate aftermath of World War II. And a lot of new countries have been formed since 1989, but Bangladesh alone was the only country that broke off during the Cold War. And in that sense, history is really fascinating. And there were also very large migrations of people that occurred during partition. And it's one of the few countries where there was an interesting tie to India as well as to the Middle East during its long history. So these are just a couple of pictures actually from the partition that occurred during the 80s, 70s and 80s. Since then, Bangladesh has been plagued by a lot of sort of environmental hazards and human tragedies. In 1970, there was a cyclone that hit sort of right around partition time. And there was actually 300,000 people that died during that cyclone. And it was actually an event that precipitated a very large war that occurred. There was a famine in 1947 or 1974. There was a coup, a military coup that happened in 1975. And I think in the 1970s, most people would have expected Bangladesh to sort of become an aid-dependent country that really wasn't going to grow and develop economically, because there were so many things that had happened to this country and the populations there. And it was a challenge. It's not a super resource-rich country. It does have a lot of very, very fertile agricultural land because basically the whole country is a delta. But there's not huge oil deposits. There's not mineral wealth. And so it's a challenged country in a lot of respects. So this was this picture right here. There was a concert for Bangladesh. When I was young, my mom always told me to eat my peas because there were starving children in Ethiopia. But I missed this sort of the Bangladeshi one because before that it was Bangladesh. There was this huge famine, and it really stunted a lot of the growth and the ability of children to thrive in this country during this era. But since that time, we've now seen what people are often termed the Bangladesh miracle. From the 1970s, we've seen dramatic increases in or decreases in fertility rate, increases in immunizations across the board, increases in primary school attendance, primarily for girls, actually. The GDP per capita has more than doubled, tripled, in fact, and the infant mortality rate has dropped dramatically, right? So we've seen these incredible gains across time from over about 30 to 40 years. And the question is, what are the innovations behind that? Why did this happen? What did this country do to come from a place where people were really concerned about the viability of the country and the population to really a poster child for a lot of economic and global health conversations that are occurring? And there are a number of different things. Grameen Bank, many people are familiar with the microcredit loan programs where small loans are given largely to women to buy certain types of machinery, so like a sewing machine, to be able to do different economic activities within the household. There was a community-based health project that actually opened a pharmaceutical company in 1981 not to develop drugs, but to produce and distribute drugs that were necessary and needed in the population. And then the one that I'm actually going to focus on is the Ministry of Primary and Mass Education. They actually, in 1990, started a free and compulsory primary education program for all students. It was called Reaching Out of School Children 2, and it was really about improving education and literacy among the population. And I'll show you a lot more about education as we move through. And then I've been working with the International Center for Diarrheal Disease Research in Bangladesh, ICDDRB, for 15, 20 years now. And they really came up with ways to revolutionize the delivery of a lot of different types of health programs. And these programs were then scaled up to other parts of the countries and actually ported to some countries in Africa and other areas of Southeast Asia because they were so effective in decreasing fertility and decreasing child mortality. So there are a lot of different things that were going on at this time in Bangladesh. So the issue, though, of course, is that when we do global health, we want to know why, right? We want to understand we want to evaluate programs and say, why are these so effective, right, in decreasing child mortality or increasing access to care or whatnot? And the problem is that any evaluation of the impact of any program that's done or that was started in Bangladesh needs something called a counterfactual, right? If we went back in time, right, and we didn't have this program, what would the gains look like or what would the population look like as we move forward? This doesn't exist, right? We can't go back in time. We can't go back and look at the same population and not have that intervention or that program occur. And so this is actually really challenging when we're trying to understand why these programs improved health and outcomes in Bangladesh so much. With a long-term evaluation, we can begin to use populations that lived before and after many of these programs went in, but we need a really, really long time frame to sort of get a large enough sample size and a large enough swath of the population to start to make some of these comparisons. Oh, and I meant to say, if you want to interrupt me and ask a question, please feel free to during the, I forgot to say that. What I have been doing in Bangladesh is a long-term evaluation, and I'll talk a little bit more about the data in a second. But there was an original survey that was done by my colleagues in 1996 called MHSS1. And in 1996, we went and did a huge household survey and collected a lot of information on a population in Matlab, Bangladesh. We just finished a follow-up in 2016. So we're talking about 25, 30 years later where we're looking at this population. And that is actually one of the longest term evaluations that has ever been done in a developing country. So the problem is that interventions that are intended to improve health and human capital and health services and all of that, they're really common in the developing world, right? There's tons of programs the global health community has tried and some have succeeded and not. But few have been introduced with a design that actually permits you to fully understand the impacts of them. The first and most problematic piece is that baseline data often didn't exist. Like, they just didn't think about evaluation from the beginning, and so no data exists prior to the time that the intervention went into effect. And that's actually where I've got them beat, because I've got great baseline data, and we'll talk about that in a second. The other one is that there's not often a comparison group. Or if there is a comparison group, they're not followed up, right? They're just sort of, the intervention is done, they look at the treatment in the comparison groups or something like that, and then they're never followed up. And we don't know what the long-term impacts are over time for these things. And even when assessment is built in to the limited number of studies, global health studies that sort of have this assessment piece, long-term follow-up is rare. So 25 years later just doesn't happen for a number of reasons, which I can talk about. And evaluation is therefore really limited to the short term or the immediate term, right? So we can't see how this might play out 35 years later. So the current study is motivated, what I'm going to talk to you about today is motivated by this sort of nexus and this dialogue in global health around women's education, right? And actually, we were talking about tweeting and all of that, which I don't do. But if I did tweet, I'd probably follow Melinda Gates, because she actually has some very interesting things to say. I am a Facebook friend of hers. And on Facebook, she talks about women's education, because education and empowerment go hand in hand. And from there, we see all sorts of decreases in fertility and increases in contraception use, and women entering into the labor force in a way that they hadn't before. And so education is considered one of those key things that really changes countries. So female education increases the value of women's time in economic activities. Essentially, women in many countries become economically viable members of the household outside of simply childbearing, right? So they can bring in an income, and they can add to the household economic structure. It also produces social gains by improving health and reducing fertility, sort of long-term completed fertility. What's interesting about Bangladesh is that sociocultural norms back in the 90s were such that women traditionally received very little formal education. Maybe they had a few years of primary education, enough to learn how to read, and from then they were pulled from school. Some were married off very early, some began their childbearing years. There's lots of different reasons. And this wasn't necessarily true of the male population. If a household was investing in education, it was typically with the male children, okay? After this program that went into effect in 1990, this reaching out to children too, there was dramatic education gains among women after 1990, to the point where there's almost no disparity between years of education between men and women anymore. And in fact, a recent study came out that showed that women had more education in secondary school than men in Bangladesh now. This is one of the first years that they showed this. So this intervention really did do exactly what it was supposed to do, which was reach mostly girls who were not being formally educated. It was fabulously successful. What I'm interested in is that there's this well-known education gradient in terms of health behaviors and health status. It goes along with the social determinants of health structure and this idea that there's this gradient of health as you walk your way up the sort of the economic gradient and become wealthier, and you see gains in health and access to care. And it's true actually for education as well. So if you look at years of education, you see increasingly better health status and uptake of health programs over time as women or as people get more education. And there's a recent study that came out that says this is not due to income. Most people would say, oh, well, maybe they're making more income and they can afford to go get health care, and so therefore they're healthier. But actually, if you net out this, there's still this education gradient that exists. So people have theorized, of course, why in the world this gradient exists. What's happening among more educated women in particular that cause their health to become better and their health behaviors to become healthier, for lack of a better term. And what we think is occurring, if you go to the health education, health behavior literature and really look at the studies here, is that increasing levels of education lead to a different way of thinking about health and healthcare access, and therefore different decision making about that. So you just evaluate your health and what is needed to maintain a healthy lifestyle in a very different way, and you make different decisions, which usually translate to higher levels of access to care or higher levels of utilization of care. And then there's a willingness to utilize health services and an understanding of why it's important, right? And there's been a few studies that have come out. This is really tricky to measure and study and understand. So the study questions that I'm going to look at today, first and foremost, between our two very long-term surveys, right, the two that are really far apart from one another, have we actually seen an overall improvement in health in our population? Has access to and utilization of care improved over this time period as well? And then what I'm interested in, are the gains in health and healthcare access the same for men and women? If we have this intervention that targeted, in particular, women's education, we should see a differential in women's improvements in access to care, and I'll talk more about that in a sec. So here is the study site. This is called Matlab Tana. It's the ICDDRB research site. It's right here. This is an old map. I'm a geographer at heart, so I have to show really cool old maps. I have another really cool one in a minute. So here's Matlab. Dhaka is right here. Matlab sits at the confluence of what's called the Meghna, which is this big river right here, and the Donagoda, which goes up this way. It's mainly subsistence agriculture, very rural. It is the site. It's only 55 kilometers from Dhaka, but it takes about 8 hours to drive there, in case you were curious. I've been out there quite a lot. during my time. It is the site of the ICDDRB's Vaccine and ORS Research Center. So this was originally set up in the 1960s as an intervention site to test the cholera vaccine that was developed in the 80s, or the 70s and then the 80s, as well as the oral rehydration therapies that were developed shortly thereafter. So the thing about it that makes it a unique place to study, and the reason we can do these long-term follow-ups, is that there's been a health and demographic surveillance system in effect in this area since 1966. So we have been studying this population, all of the demographics of it, births, deaths, migration, marriage, since 1966. And we have a long-term population database on these folks. We have very precise ages. We know there was a baseline census that was done in 1974. And the other thing is that there's this vast wealth of geographic information systems data. Yeah?
Could you back up a little bit and explain why this innovation in education occurred in Bangladesh and not, for instance, in Pakistan? What was the driver there?
For why they decided to try to increase education in general? Personally, I mean, there's a lot of theories on this. I think that the ministry, sort of the government at the time period, and the Ministry of Health and the Ministry of Education started discussing why India was seeming to do better than they were. So this is a dominant question when you work in Bangladesh. Why is India doing better than us? Right? They're right next door. Our populations are very similar demographically. Why is India doing better? And India had actually already started a major education campaign in the 1980s to try to improve levels of education across the board. And that was inspired by a lot of economic research that was done that showed that education did increase GDP and countries, just large-scale development prospects. By creating human capital, right? The idea is you're creating a well-educated workforce, and you're improving human capital, and so therefore there should be economic gains from that. And so Bangladesh actually sort of followed in the footsteps of other countries that were doing something similar.
And how did they finance this?
Not well. I mean, the budget has always been a bit of a wreck in Bangladesh, but if you've ever been to a Bangladeshi school, one of the things they did is they don't have all-day school. They have shifts at school. And they started with 2 shifts, and now they have 3 shifts at school. So you might go from 7 o'clock in the morning until 11, and then the next shift comes in from 11:30 to whatever. And so they've actually partitioned the school day to be able to bring in more people, but the teacher's still being paid the same. And you don't need additional buildings. You don't need infrastructure for it. So they made shifts to the way that education is actually provided within the country. Now, you can ask the question of how much education is a child who's only getting 4 hours of schooling a day, and they're sitting in that classroom with 40 other children. How much are they actually retaining and understanding? I have a friend who is researching education. Maybe I'll send her out for the Davis lecture, and she can talk specifically about that. We have this site right here, Matlab, and I was saying we have this GIS data. So basically, my PhD advisor collected this first in 1995 at about the same time that MHSS1 was done, so the first wave of the survey. And so we know where people lived. We know where the schools were, where health facilities were. And we did the same thing with the next surveys. We collected all this geographic information. We built this big thing called a geographic information system. And we can look at things like population mobility and migration and environmental health and all sorts of stuff like that. So it's one of the few places in the world where we have spatial information as well. So this is Matlab, actually. This is a historical map that I found when I was doing a records review at ICDDRB a couple of summers ago. And what's very interesting is they actually had 2 locations in Matlab where this is where they did a family planning intervention, and these areas is where they didn't. So they actually did a randomized control trial, in some respects, population level of maternal and child health and family planning programs. But this is what it looks like, and here's the Meghna, and here's the Meghna, and here's the Donegota River. Oh, that's the Gumti right there. It's down here is the Donegota. So let me tell you about the data. And feel free to ask questions. This is a really complicated survey and survey design that was done. The Matlab Health and Socioeconomics Survey, which I call MHSS1, was done it was completed in 1996. It was started in 1994, and it took about 3 years. Partially because there was an election that occurred right in the middle of it. and you can't really get anything done during election season in Bangladesh. It is a representative survey of about 5,000 households and 24,000 individuals in the Matlab area. It was about an 8% sample of the population at the time. And it has detailed health, labor, and socioeconomic data, extremely detailed. The household survey on average took 6 hours. You would go into a household, you would do a household module, and then you would interview every individual in that household, and the whole process would take about 6 hours. And that's this one. The other one is longer. And you think, my God, how did those people sit and do it? And they do. They're actually interested in talking with us when we go into their homes. We also had observed health data, and we did some very limited cognitive tests. Mini mental state exam, some number digit span, things like that get at short-term memory. And really what this was supposed to do was it was supposed to allow us to model programmatic effects of that MCH, that Maternal and Child Health and Family Planning Program. So that was one of the main goals of it. And it did that using an age cohort design. So there were certain people that were interviewed that had been exposed directly to the program, and there were certain older people that were interviewed that were past their fertility and really weren't exposed to the program. So it did sort of it's age cohort or a wedge or step design. And then we get to MHSS2. This was just completed in 2015. It took, again, about 3 years to do, and it's actually a much, much larger sample. It's over 10,000 households, and it's actually closer to 40,000 residents. It's based on the MHSS1 survey. So we did make modifications to the original survey, but we tried to keep a lot of things consistent so we could make comparisons across time. What's very interesting about this survey is it is longitudinal. So we followed up as many of that original 5,000 individuals or 5,000 households, 20,000 individuals as we could find. We did extensive migrant tracking, following people to Singapore and Malaysia and the Middle East and Sylhet and Chittagong and all these cities within Bangladesh, and managed to get about 96% of our original sample, which is unheard of, right, in longitudinal studies. That's why it took us actually took us about 4 years to get all these data, okay? And then on top of that, we did a refresh sample. And we also followed descendants. So we'd have an original household, and we'd actually look at marriages that occurred in that household and interview the married person and then the children, partially because we had somebody who was very interested in looking at intergenerational effects. Right? They wanted to see if the children of the people who got the intervention actually saw gains. The short answer is no. There's apparently a memory to these things, so there wasn't a lot of gains in the grandchildren and children. There is also a community and a facility and a market price survey, which I did pull some data from, which is why I mentioned it. We did a lot of national facility data, so we went to the government of Bangladesh and said, where are the schools? Because they actually know that sort of information. We then created something called the Matlab linked database, and what it does is it links these people across both surveys and to the original census data. So we have this cohort following forward of over 10,000 people. It's a pretty amazing effort. We just finished cleaning the data, like the end of last year. So what you're going to see in terms of what I'm presenting is brand new, right? We're just starting to work with the data now. So how do I create this counterfactual, okay? This is my sample selection strategy. The intervention was done in 1990, okay? Our survey was done in 1996. So really, we kind of missed the boat with baseline survey because we didn't collect data truly before the intervention occurred. But if somebody was born before 1974, it means that they had aged out of elementary school by 1990. And so therefore, they were included in our sample, but they never would have been part of this education opportunity intervention, right? And so they're not, we call them the not intervention group. And the age range of these people are somewhere between 16 and actually 95 years, right? So we had this group of people. On the flip side, in 2015, in the MHSS2 survey, we wanted to capture people who were included in this intervention, right? Who would have had direct impact of this educational intervention. So they had to have been born in 1984 or later so that they were elementary school aged by 1990 when the intervention went into effect. So this creates the intervention population. And their age range in the data set from 1 to 30. So fortunately, because we had such a long-term follow-up, we end up with a sizable enough cohort to actually look at the impacts, at least in terms of sort of prime childbearing age in Bangladesh, like up to 30. So when you stick those two things together, we basically get a cohort of people between the ages of 16 and 30 from both ends, both sides of the data set, where we can truly try to see if the intervention itself had some sort of significant effect on health. Yes? So yes, for the right. So yes. So for the family planning, project, right? We're basically for the education one. I'm only pulling out. I'm not looking at intergenerational effects. I'm only looking at the direct effect of education on these women. So in this particular presentation, I'm not looking at that. For the family planning program, what happened was do you remember that map where there was the dark area in Matlab and the lighter color in Matlab? So the MCHFP program went into the dark area, and then about 10 years later, it went into the light area, right? And so what my colleagues have been looking at is you have this group of women who, right, had the direct effect here, and then they later had the direct effect here. And then we can look at their children now, and their children wouldn't have gone through this phase in their life, right, and been impacted by it. So, but this I'm really looking at direct effects here. For this one. So the data that I use is there's comparable questions across the two surveys on health, access, and utilization of care. Okay, there's person-level demographics: age, sex, religion, literacy, years of education, marital status, all sorts of stuff that you'd want to know. Because in reality, right, even though we have two cohorts, one with the intervention and one with not, things did change a lot between 1990 and 2016. And so we need to control for some of these baseline population level demographics that have shifted over time. There's a wealth index. I'm going to talk quite a bit about that because it's actually one of the interesting findings in and of itself. I created a women's status index. We asked a series of questions on women's status, and I'll go a bit more into that. And I can pull out availability of health services, which you would think would impact health access to care. So these are the data that I'm going to use. These are the questions that I pulled that we're going to look at as our outcomes. Okay, the first one is just a general health status question. We love to hate this question. It seems really silly, but it shows a lot of variation, and it's actually a really good indicator of health across the board. We used a combination of two questions to create a metric of whether or not somebody was healthy or whether they considered themselves to be unhealthy. There's a question about need. So have you ever needed care and didn't get it? Okay. And there's two utilization questions. One about have you stayed overnight in a hospital, and one have you had outpatient care in the last 12 months. So we're kind of covering the gamut on access, utilization, and just general health with the questions. There's a lot more than this. These are the ones that I was particularly interested in, and I made sure they were consistent across the two surveys when we were designing the second survey. Women's status. This is a really tricky thing to get at because theoretically, one of the theories is with educational gains, you'll have increases in women's status. And in fact, women's status has gotten better in Bangladesh over time. We asked a series of 15 questions in both surveys that got at freedom of mobility, household decision making, whether or not women are earning money, whether or not they're working outside of the home. This is just a sampling of the questions that were asked. And we could create an index out of this that sort of gets at sort of where on the hierarchy do women fall in terms of status. There's also a gender equity scale we did, which some questions that didn't work very well in this cultural context, and we're still trying to figure out if that one worked, but it would be interesting. So I used a variety of statistical methods. I'm not going to go in super depth on these, but I'll give you just a brief sort of overview of what sort of modeling strategy I used. Principal components analysis to create the indices, pretty standard. The wealth index is actually the exact same one that the DHS, the Demographic and Health Surveys, used. I used their methodology. And then I looked at univariate trends just to see what things looked like over time, since we haven't even done that yet. And then I did do a difference in difference regression model to examine differences in gender over time. And we'll talk about this. There are people that are clustered within households, so we had multiple people in households, so I did adjust for that inter-Bari correlation or inter-household correlation with the models. So let's talk about this a little bit more. So the idea behind a difference in difference model is that we're looking for a difference in slope between two different groups in a pre-period and a post-period. That's sort of the bottom line. So if we have our first cohort from MHSS1 and our second cohort from MHSS2, and we want to look and see whether or not the education benefited women in terms of their health gains more than the men, we look at these two different groups over time. And what we're looking for is a difference in the slope right here, basically to see if women made greater gains in health and access to care than men over this time period. And we can then theoretically say that it's because of this intervention, perhaps, right? So that's what we're looking at. These models are very interesting to me because it doesn't assume that the baseline outcomes are the same between the two groups, right? They can be totally different. And in fact, you'll see men and women that the access and healthcare are very, very different at baseline. It does mean that they were theoretically on the same trajectory beforehand, right? So they have to have sort of had the same slopes beforehand, and then the intervention caused that shift in a slope. So more technically, if you're into equations, which some of you may be, this is a very simple difference in difference equation. It has a couple of interesting terms. This is the different groups, right? So men or women. I have my two different groups. This is the time period, which is the pre and the post. And then you do an interaction term between the two, between the groups and the treatment, or in this case, the education intervention. And what we're interested in looking at is this beta coefficient right here. Because what this is going to tell you is if the slope between men and women is different over time. And that's what we're looking for, right? We're looking for that difference right here. So the data, or the results, I guess I should say. This is just briefly looking at changes over time. So these are my major health outcomes that I was interested in. And what you can see is that there's actually a decrease in health status over time, which I would love to entertain discussing more in just a little bit, but let's leave it for now. There was a decrease in the people who said they couldn't get care. The little star does mean that there are different significant p-values between the two different groups. Huge increase in hospital stays. I will actually talk about that. And then a pretty dramatic increase in people who utilized outpatient care. So in general, we see slightly worse health status, at least to how people rate it, but all of the indicators of access and utilization are looking good for this. These are the differences between men and women. And actually, I'm going to look at it this way because I see this as much easier. So this is the current health status, and what you can see is that there are pretty big differences between men and women for both years. And this is whether or not the simple difference in difference model, which term was statistically significant. So all we see here is in current health status, there's a difference between men and women. There's not a difference between years, and there's not an interaction effect. So it doesn't look like women are making more gains or men are making more gains relative to women, okay? Right here, this is the needed health care and couldn't get it. And what we see is both a year effect and that interaction effect. So there's differences across the 2 years in needed health care, but they couldn't get it. And what you see is actually a divergence between men and women. So we have more women saying they couldn't get health care when they needed it, and actually fewer men said they couldn't get health care when they needed it.
Are these adjusted?
These are not adjusted yet. I will get there. This is stayed overnight at a hospital. And again, we see that there is a gender by year interaction here. So women actually made really big gains here, and that slope was significantly different from men. So they made more gains in this particular one. Yes, so we're going to talk about that. The rise in hospital births among women in Bangladesh. Because I looked at this, I was like, oh, what's happening? And then I was like, oh, yeah, we have hospital-related births at a much higher rate than we used to. And then this one is receiving outpatient care. And there's a very slight gender difference here. We see a marginal gain by women in this particular one in receiving outpatient care, but both men and women increased over time. So we're seeing a lot more uptake of use of outpatient care. So here's some really interesting things about the demographics. This is the one that I think is amazing, right? The literacy rate is now about 91%, up from 61%. So these cohorts are fundamentally different in their ability to read and write, sign their name, lots of things like that. I also thought it was interesting that the marriage rate was much higher in the later cohort. There has definitely been a shift around when and who gets married because women are economically bringing in more money to households. And so we're seeing this reflected in the demographics. The other things that are really interesting is here's the educational gains. And I'm going to look at this in more detail. But the average years of education went from 4.4 to 7.5. The goal of the government is 10. Everybody should have 10 years of education. But this gain is monumental, right? That's massive gains over a period of 25 years. This is puzzling. It looks like the wealth index that I created. It looks like people are getting poorer or that their households are not as well off. I'm going to discuss this in detail in a moment as well. One thing I will say is that the wealth discrepancy or inequality has gotten massively larger over time. So there's a larger group of people who are wealthier, but the range is much greater. So the standard deviation here is actually much larger. And then we do see gains in women's status over time, which is encouraging. So here's a closer look at the educational gains. MHSS 1, our first cohort, is in the gray bars things. And then this right here in the red is MHSS 2. And you see this shift. This is women and this is men. You see a shift from a very large group of people not actually having any formal education to almost nobody having no formal education. So this alone implies that the program is working quite well over time, right? So there's that one. And then this is the literacy gains between men and women, right? So we see large literacy gains, but look at this differential between men and women. This actual difference between men and women in MHSS 2 is statistically significant. So there are more literate women in my study area than there are men by the later period of time, which is quite extraordinary, given especially that men had a higher rate of literacy in the pre-period. So what's going on with this wealth index? So I originally wanted to include this as a control in my model, right? Because wealth is an important part of access and utilization of care. And when I started looking at the effect, I was like, something's not right here. What's going on? And so I mapped it out to look at what's going on. And this red, again, is MHSS 2, the later time period. And then this is MHSS 1. So the wealth index performs, like the creation of it and what goes into it, performed very well for MHSS 1. But there's something not quite right here, right? First of all, you've got these weird peaks like this. But you also have a very large cohort of people that seem to be really not wealthy. And it wasn't matching up with the health outcomes at all. This is what I think is happening. There's a huge increase in wage labor. And there's also a huge increase in people who are leaving the household entirely and sending money back, right, as migrants. They're sending money back to their households in Bangladesh. This does not really translate in the same way to household assets and improvement in housing as it did in 1996 for some reason. So people are making money, and they're not necessarily spending it on the same types of things that they were in 1996. The other thing that's happening, this wealth index includes assets, it includes agricultural land, it includes cows and chickens and ducks and goats and all of that, if you look at the DHS. And the population growth has actually translated into smaller agricultural plots. There's lots of very interesting laws of inheritance in Bangladesh. And so families are subdividing their plots. And so people have less land, even though they still have land. And that goes into the wealth index. And it looks like they're not doing as well because they have less land, right? But in reality, it's about inheritance laws. There's also a decrease in subsistence agriculture overall. There's a decrease in farm animals. People don't have the same number of cows and chickens and goats that they used to. Because they're actually living in an apartment complex with their wage labor, and they don't have these things. This translates into a lower wealth index. So what this isn't and the other thing is the shift in household assets. The original survey, of course, didn't ask about cell phones and computers and solar panels. They didn't really exist at that time period. And that's what people are spending their money on. Everybody has a cell phone nowadays. And in fact, most households have 2 or 3 or 4. And that's where the money that's being sent back or being made into these households is going to. So my conclusion is that this wealth index is completely useless in MHSS 2. And we need to find a better way or a different way of measuring household wealth. We did do a consumption module. I don't know if any of you are economists in the room, but it basically goes through and asks a household exactly what they bought over the last week, 30 days, and a year. And how much money they spent on it. And you can create an index of consumption, basically what the household is consuming. The problem is they don't match up very well between MHSS 1 and MHSS 2, and we're working on trying to create a metric that will work across both, because it was modified a lot for the MHSS 2 survey. Yeah?
I'm trying to figure out what a household is in 2 time frames. And one that maybe had, mom, dad, grandma, and 3 kids.
Yeah.
Say. They now, at time 2, it's a panel, right?
It is, although remember, we're not following the same group. We actually have 2 different groups in the time 1 and the time 2.
Okay.
Yes,
so
it is a panel.
Okay, so that's so. Now I'm confused. So who are you comparing that family I just talked about?
Yeah, it's 2 cohorts.
2 cohorts.
Right, but
Not connected at all.
okay, but what are you doing about the fact that this region the city that you're studying, or this rural area that you're studying, the composition of it is very different today than it was 20 years ago?
So what I would say to that is that household structure has not changed that much. There are fewer children in households, that's true, because the fertility has dropped from like 4 to 2.5 during the 2 time periods. But the structure of the household is still the same. So you have a head of household, and you have his wife, and you have their children, and you typically then also have grandparents in that household, and sometimes great-grandparents in that household. The other thing to note is that people in Bangladesh in this region live in something called baris, and they're actually patrilineally related clusters of households. And so not only do you have a household, you have a bari, which includes other family members as well. And this fundamentally has not changed in the 30 years that I've been looking at the data.
So you don't have a selection of better off people moving to Dhaka?
So yes, we do. And that's one of the reasons we did the migrant tracking survey, is we folded in that group of people too, so that theoretically we don't have the bias of out migrants leaving for Dhaka.
Because if the better off people left, that might also have something to do with the wealth index.
It's true, but the issue with the migrant population is that they still wouldn't perform well on this wealth index because they're making money, right? They have a household income. They don't have land, they don't have cows, they don't have chickens, they're not buying.
All right, sorry.
No, it's all good. So I just think this is not performing well anymore. We need to somehow work in wage labor and household actual income into this as well.
The nature and the purpose of wealth is different in the 2 cohorts. If I'm a farmer, if I'm a farmer, my chicken, first of all, I need precautionary savings because it may be more fluctuating than wage labor. But also, I own the capital that I need for my labor.
Yes.
When I'm a wage laborer, there's a machine that I don't own that is generating my salary.
Right.
That is a complementary asset to my income. And so it's very. So it seems like it's probably worth unpacking that and say whatever's happening with the wealth index.
Yes.
Here's the wealth that's required